definition that we have. The ADA, the American Diabetes Association, has given us a very, and it was coined in 1997. It's a group of metabolic diseases which are characterized by hyperglycemia, that's high blood sugar, which results from either problems with insulin secretion or the action of insulin, or both of it. So it's not only where there is no insulin. Sometimes there is insulin, it's not working well. Sometimes there isn't enough insulin, or sometimes it's a little mix of both. So why are we so concerned with diabetes? Because the chronic hyperglycemia that diabetes has is associated with a lot of long-term, almost practically permanent damages. A lot of dysfunctions and failures of various organs. Specially targeted organs with hyperglycemia are the eyes, kidneys, nerves, the heart, and also the blood vessels. So very quick into the history. Around 3,500 years ago, actually, were the first documentation. So there's been an Egyptian papyrus that has been found, which looks a little bit like this, which is the oldest preserved medical document about diabetes. It's in a hieroglyphic script, and it mentions the concept of polyuria, something that we know very well about diabetes, polyuria, polydipsia. So polyuria is mentioned in this particular document, and it was discovered in 1872. And the term diabetes is also pretty old. 2nd century AD was when it was first used. In India, in even our ancient medicine by Charak and Sushruta, there too, diabetes was actually identified and even classified into type 1 and type 2. They had found an idea of urine that attracted flies, honey-like urine, and they realized that that was glycosuria. There was sugar coming in the urine, and that was the basis of understanding and then treatment of diabetes down the line. And there were two separate conditions very clearly identified by both Charak and Sushruta. And it was noticed that type 1 had more people who were younger and underweight, and type 2 had people who were older and overweight. So that's when people started thinking, the cycle started going on, when we needed to study where it all came from, and we started studying the pancreas. A little bit of the history. 1869, we've heard of islets of Langerhans. So he found that there was some other thing, the hormone actually now, that was being secreted by an area from the pancreas, which later was called the islets of Langerhans. In 1889, Oscar and Joseph, they did an experiment where they detected sugar in a dog's urine, and then they did a little bit of research on that particular dog's pancreas to find little changes that was happening over there. In 1902, Eugene Opie provided very convincing evidence that the source of the secretion, the hormone, actually came from those particular islets of Langerhans, and that secretion, that hormone, insulin, was the link between metabolism of carbohydrates and the development of diabetes. So then comes the discovery of insulin. So we've all heard of Banting and Best and MacLeod and Collip. So it was somewhat by chance. An orthopedic surgeon, Banting, he was asked to take a lecture in physiology, where he started studying a little bit about the pancreas. And then one of the students, Best, both of them together discovered insulin. They were working under the professor of physiology at Toronto University, John MacLeod, and they took the help of a biochemist, James Collip, to identify and purify insulin and make it available for treatment of diabetes. So this is Leonard Thompson. He was the first known patient of diabetes who was successfully treated with insulin. And why is this so important? 1922 to 2022. It's been 100 years since we have insulin, and so much information now that we have on diabetes, and it's still going on. We're still learning more and more. So 1923, the four of them, they were awarded Nobel Prize for Medicine and Physiology, and it's down in history. So 100 years, this is actually a clipping of the original newspaper from Toronto, March 1922, and it's 2002, 100 years of insulin now. So these are little landmarks in treatment. So once we know a little bit about diabetes, we need to know how we are treating it. So 21, we just heard about it. Insulin was discovered, it was crystallized. 1946, NPH, one of these slightly longer acting insulins were found. 1955 was the first oral drug. And surprisingly, before biguanides, actually sulfonylureas came in. But it's not the sulfonylurea that we know today. It was carbutamide, which isn't available anymore. But that's 1955. We had lenti insulin in 56. In 57, fenformin came in. So it's been a good 50 years that we've studied and learned about biguanides, and that's why we trust metformin so much. 63 comes in pre-mixed insulin that helped us with long-acting and short-acting together. 1978, we started using the insulin pump. So much revolution has happened in our inpatient treatment with the help of insulin pumps. Recombinant human insulin was approved in 1982, and very, very fast developments have been happening. 1995, acarbose was found, was approved. Then we've had our glitazones, found in 97. They came and they went and they came back again. 2005, we've got GLP-1 analogs, and we started using basal insulin. So again, a large leap in the treatment of diabetes. 2006, the first DPP-4 inhibitor was approved, and 2012, so it's even been 10 years of this now, SGLT2 inhibitors, canagliflozin, we found those, and now we are using them with a lot of success. So now a bit of statistics. So worldwide, above 460 million adults are affected with diabetes, and it's growing. The global rate was expected to grow to 578 million by 2030. It might be even more than that. And it's going to cross 700 million by 2045. So it's exponentially growing. And we've noticed that diabetes these days is increasing more in low and middle income countries, especially India. India is becoming one of the capitals of diabetes. At present, China has the largest population, but then India is not far behind. And USA, although the landmass is bigger, but China and India are leading when it comes to number of diabetes patients. So in India, it's increasing from 32 million in 2000. In 2013, the last census, we had 63 million, so double. 1 in 6 patients in the world, diabetic patients in the world, are from India. And the number is projected to grow to a very high number, even more, a double of what it was already per IDF. When we do a little bit of a statistical survey of the patients that we get in our general medicine OPDs, 20% of them are diabetics, and many, many more are pre-diabetics. We've noticed that it occurs earlier. So if it's occurring in the 40s and 50s in the West, we are seeing more of 30-year-old, even 20-year-olds sometimes getting diabetes here. It also happens in people who aren't traditionally obese, a little bit overweight with little skinny arms and big bellies. They have more diabetes than we would expect to see someone who's blatantly obese. And a lot of heart problems happen in the Indian diabetics, more than the microvascular problems. We see a lot of more cardiovascular problems. And like I said already, so many of us already have pre-diabetes. And that's where, if we as family physicians can actually reach out to them and tell them that you have a condition that can possibly turn into something chronic, progressive, and we can stop it now, we can prevent the progression. And even when it does progress, we can try and make sure it doesn't progress to a level that is difficult to manage. So a lot of counseling, a lot of hand-holding, a lot of acceptance by the patient who is required, and that's where we need to help. So urban India is kind of blissfully ignorant, unfortunately. 25% of people have not even heard of the word diabetes. 60% don't really know how they can lead to organ complications. And that's why there is a lot of hesitancy to start treatment, thinking that, oh, it's okay, probably go away on its own, or I'll start treatment later. But the longer the individual is exposed to the hyperglycemia in the system, the more possibility of permanent complications. So 80% people don't know what they were doing wrong that led them to get diabetes. So there's this family history, there's the poor lifestyle. So more than 80% don't know that they could have done something to have prevented it from happening. And 60% don't really know that with a good lifestyle, you can prevent it or at least delay the onset of frank diabetes. So just a good, healthy lifestyle helps in so many ways. So unfortunately, Indians are a bit more prone to diabetes than others. So there are some reasons because of that. So there's some genetic factors. We have more insulin resistance and we end up having a more postprandial glycemia. That's why the yo-yo of our sugar metabolism is very, very prominent. There's a lot of fat deposits in the abdomen. So if you look at the typical diabetic figure, we'll have stick arms and stick legs and a big, large tummy. And the visceral fat is kind of a precursor to diabetes. We have something called metabolic syndrome where the triglycerides are high, the good cholesterol is low, there's insulin resistance. This kind of invites diabetes sooner too, and it's more common in the Indians and other around us, the subcontinent. There's a lack of physical activity. There isn't much space really in the cities to exercise well. Gyms are a bit expensive, and realize that some physical activity that they could actually add into their daily lifestyle would have helped them to prevent diabetes from happening. There's a lot of migration that's happening these days, people moving from the rural areas to the urban areas. So that means a lot of technological development, which means that we are doing physically less work, and most of our work is in front of the computer or sitting on a chair, and that doesn't really help the cause. During pregnancy, women tend to or are advised to take it too easy, sometimes more easy than is necessary, and that leads to a sedentary lifestyle and a higher calorie diet. So there's an idea that one, when pregnant, needs to eat for two, which that's really not the case. You just need to eat a little more, just enough for the developing fetus. But when we eat too much, that can lead to a development of gestational diabetes, which in the long run is a precursor to full-fledged diabetes too. We are also, we have this treatment inertia. We don't really want to go to the doctor. So many patients actually sometimes occasionally even test their sugars on their own, but they just don't want to go to the doctor with the results, fearing of maybe multiple big long prescription that they might need to take lifelong, and the fear that they have. So that's the job of the family physician here. We need to help the patients overcome that fear, understand how getting treatment early would help them in the long run. Our diet usually has a lot of starchy food. So the Indian vegetarian diet is usually carbs with carbs, rice with a potato ki sabzi, rice with a mixed vegetable sabzi, which has more root and starchy vegetables in them. So in that way, we really don't have enough proteins, and it's not really balanced. Even when we're taking fruits, the carbohydrates, sweet fruits are the ones that we prefer more. So there's more mangoes instead of having more citrus fruits. Sometimes our festival foods are more sugary, more oily, and that's where our diet also makes us more prone to being diabetics. So again, if we look at this little study that was done by Dr. Mohan et al., we found that 50% of the cases were actually undiagnosed. So people who had normal sugars, that's 75% of the cases, but then with 25%, there was already impaired glucose tolerance, and 15.5 didn't really know that they had it. And dividing that, there was only around 40% of people who reported diabetes and around 60% who didn't even know about it. So what happens when diabetes is uncontrolled? Possibility of having a coronary artery disease is very high, 21.4%. Retinopathy, which can lead to permanent blindness, 17.6%. There's neuropathy, which is pretty common, and many a time patients will come with complications of neuropathy, and that's why we need to look at the food so often, 26%. There's peripheral vascular disease, where you can see a gangrene has happened and the entire toe is dark and gone, and this person will need an amputation. That's 6.3%. And then there's nephropathy. So although not a very high percentage, but can be absolutely fatal and very, very debilitating. So the government has tried its best to bring the awareness out about diabetes. They have a national program actually for prevention and control of diabetes, cardiovascular disease, and stroke. That's what NPCDCS stands for. And it was started by the Ministry of Health, Family Welfare. It was launched with an objective to reduce the risk and prevention of these non-communicable diseases, because it increases our morbidity drastically. There was a pilot that was launched in 2008 in 10 districts of 10 states, and it's okay, it's running on the side, covers a lot of sub-centers. We've got a lot of people that has been screened, and we have these camps and all. Many professionals have been trained, and the strategies are to promote a healthy lifestyle, screening of people, setting up clinics for regular checkups, and developing of trained manpower. So along with the government, we need to hold hands, and we also need to help our patients understand this. So why the family physician is apt in managing diabetes? Because we have the unique quality to manage chronic diseases, because we are available, we are affordable, and most of the time we would be acceptable. Just a moment, yeah. Sorry. Most of the time we would be acceptable to our patients. So we are the best people to catch something like this early and start the treatment early and make sure that we are managing it well. So our defining features in our textbook, the first thing, what does family medicine do? There's continuity of care, there's comprehensive care, and there's coordinated care. And that's where we are well equipped to treat patients of diabetes and other chronically ill patients. So the large majority, in the end, we are the ones who are going to keep on caring for the patients. We are the primary care physicians. The patients are going to come to us for the majority of their problems. And that's where we need to know about diabetes and be confident in the treatment. So worldwide, a lot of studies have been done where pharmacological and lifestyle management by the family physician has considerably reduced mortality and morbidity from the problems that we have. Okay, right. So you've seen this before. We've discussed this in our previous lectures. Wagner has given us this model of chronic care, and this again fits into diabetes management. So these 6 points of diabetes management we'll be discussing a bit, which will lead to improved outcomes by giving us an informed and activated patient and a prepared proactive team. That's a team, that's us. So ADA has picked up the points from the chronic care model and talks about a delivery system design where we are proactive instead of being reactive. We are going out in the community, we are making policies, we are helping patients identify about diabetes, help in self-management support. So constant training with diabetes educators, with exercise trainers, with dietitians about how to use your self-management devices, constant training on that. Decision support. So we have to have evidence-based care. That we need to keep ourselves updated. We need to know about the changes that are happening, and we need to be in contact with endocrinologists, with other professionals, so that we have support when we are treating these patients. We need to have a good information system, nice roster where we maintain the information about the patient, so the follow-ups are much better. There needs to be community resources and policies where the government is already there. We just need to push our policies along with them, work together, and we have to have quality oriented a healthcare system culture.